Hello, my wonderful YouTube family. Today is going to be a doctor's appointment that I've been waiting for probably around a year. And in all honesty, now that it's coming to fruition, now that it's here, I really just am not as nervous about the whole thing, about my cyst. But the whole thing that I'm nervous about is the surgery to get the cyst removed. Now, we know that I have autism, and we know that I have problems processing. So it's going to be interesting to see, with those two things in mind, how my doctor delivers the information to me. So I'm going to be taking you guys along for the ride, and we're going to be cautiously optimistic here. So I'll see you guys in the next video. So guys, now that my doctor's appointment's here, we are in the car driving to the hospital, and I gotta tell you, it's gonna be a good time regardless of the news that we get, because I'm just ready to get this cyst out of my head. We are really hopeful that they're gonna be able to remove it all, and I am hopeful that my processing speed will skyrocket as a result of the cyst being removed. So please don't forget to rate, comment, subscribe, and click the notification bell so you never miss an upload from me. I'll see you guys in the next video. I'll see you guys later.
I don't know. Will it help? It might help barometric pressure headaches.
Yeah, it might.
It might, it'll definitely help the, probably what we thought were cervical headaches.
Yeah.
Because that's the area of the cerebellum where the pressure is. I don't know if I really want to do this, but we'll find out.
And I guess one of my questions for the doctor would be, with all the research that's been done, how prevalent is the I wouldn't say cure, but how prevalent is the fix?
How prevalent or how successful?
Yeah, how successful.
Okay, yeah. So that's kind of what I was saying about what are the chances that this is going to be a permanent fix?
Yeah.
What's the success rate of this as a permanent fix? What's the chances of a recurrence? I did need to be in the alley. Is there someone right behind me?
No.
Okay, good. Anyway, the thing is, if you have, let's try and do this with round numbers. If you have 2,000 cases, what's 1% of 2,000?
Yeah, so that would be 20.
Yeah.
Or no, 200.
200. But if you have 20 cases, what's 1% of 20? Like 2, right?
Yeah.
Yeah. Or 0.2. I have to focus more than I should while I'm driving. Anyway, it's way small. So since there is such a small occurrence of this and a small number of documented cases, percentage rates are almost just, they don't really tell you a lot.
Right.
What is it? 2 does not make a trend, right?
Yeah.
And if you're looking at percentage, now if they were to say, well, half of the known cases have a recurrence, that's kind of big, right?
Yeah.
But if they say 10%, that's 1/10. So 20 divided by 10 would be 2.
Yeah. And guys, just so you know, we're chasing zebras. We're just about to the hospital here, guys, so I'm gonna sign off for a bit, but I'll get back to you guys later. Alright guys, so next step here is going to be an x-ray looking for any neck movement, and that's going to be down and back up past midline, and we're just checking all the boxes here. And guys, if I haven't said it before, I'll say it now. I really do appreciate all of the subscribers checking in on me throughout this process, and it's you guys that really make me feel wanted and make me want to do more of these videos with regard to my medical situation. So thank you very much. Is that right down here in here where the fluid would normally be? See that little hole? Yeah. So somewhere in here is where we're looking at a cyst that keeps the fluid from going out into this area. So point to that again. Okay, so we're looking at, see where the flow comes out here into this area. Yeah. That they're looking at this area for a possible cyst. And there was a shadow when they started looking at it really closely. There was kind of a shadow there, not really a shadow, maybe a little bit brighter area there that looked like it could be the edge of a cyst right here. Yeah, that makes total sense. Okay, so they were saying that there was some reflux into the area, or into the fourth ventricle. And reflux, I think of being, like a something that gastrointestinal, but it means that fluid is coming back up where it shouldn't be. And so that would, and they were saying that there was reflux in the vicinity of the fourth ventricle. So that would make sense that this is coming down here, hitting something, and then kind of bouncing back up. The fourth ventricle is extremely enlarged. I wish, where's my other picture? Here we go. So I kind of tried to sketch it out here with this dotted line. It looks like the fourth ventricle is that big. I mean, what I was saying, it looked like the cerebellum was really
had a lot of impingement, a lot of pressure being put on it, and it was larger. Now that may have been kind of a misrepresentation because I'm looking at a two-dimensional picture here, and what we were looking at on the MRI was, different slices. So it may have been.
Guys, with everything that we just went through with my doctor's appointment, I think it went really well. We got some really good information, and we're moving forward. I mean, yeah, with the whole thing about the arachnoid cyst, it really does concern me that we've let it go for so long. But it does my brain good to know that we actually have a plan in place now.
Because we're not talking about a cyst right in the middle of and filling up the fourth ventricle.
Right?
But, sorry, let me focus on getting out here without getting broadside in. Good luck getting into that little spot. So if it's in the fourth ventricle, it's barely in the fourth ventricle, right?
Yeah.
But it's causing backup of CSF fluid into the fourth ventricle and the severe enlargement of the fourth, right?
Yeah, that's my understanding.
Yeah, okay. So I definitely, when we look at the amount of time we've been looking for this thing and all the other stuff that we've tried, I would say that, let's see, this doesn't say no left turn, so we're going to try and make a left turn here. As soon as this guy comes past. There's nothing back there that says no left turn, guys.
So anyway.
Yield to, I don't, there we go. They're making a left turn. I'm sorry. Yeah, go ahead. Did you have a thought?
No, you were saying something.
Well, just that since we have looked at and eliminated as the primary cause of your headaches so many different things. I mean, we've looked at, I think, pretty much all of the horses. And I think that the doctors are kind of running out of ideas. Right?
Yeah.
So, I think the call, to go ahead and go in is the right one.
Quacks like a duck, it probably is a duck.
Yeah. There you're turning to the left. They are not. What is this guy? This guy's going straight. You don't have a stop sign. Okay, Lisa, settle down. It is a confusing area. This is an always stop.
Back at the ranch. So, with everything that we know, with everything that we know now, where does that put us?
You're asking me?
Yeah.
Pretty much in the same spot as before the appointment. Although we found that the cyst is not directly in the fourth ventricle, it is either right at the, just barely inside it at the outflow point, or it might be completely outside the ventricle, but preventing outflow from the fourth ventricle. So that still puts us in pretty much the same place, that we're not going to really find out much more about this and exactly what it is until they do surgery. And at the same time as they do the surgery to find out what it is, they can also, hopefully they will find a cyst there, and they can go ahead and resect, so remove part of the side of that cyst so it drains, and they remove a large enough portion of it that it doesn't just heal over and refill.
Yeah, I'm hoping so.
Yeah.
But then again, that releases more glutamate storm.
Probably not so much, because they're not going into the what is it, the cerebral cortex. They're not going into the upper part of the brain. They're going to be entering through the back of your head, along the spinal cord, in that foramen magnum area, and then go up from there. They may have to take out a little bit of bone at the entrance, but there should be space for them to go through.
Yeah,
to
there
this
should.
area. Yeah, so it's not like they're going to have to go through the upper part of your brain like they do when they are doing a shunt catheter revision. So,
right.
Hopefully you won't see that. That's a good question, though, for the doctor when we go back for the pre-op.
Yeah.
They do more recovery time than just a basic shunt revision. Yeah, that this is a more sensitive area that they're going through.
Right.
So, it sounds like you're going to be in the hospital for a bit. I don't know how long. And we would probably expect some pain, post-surgical pain in that area.
Yeah.
But if it takes care of your headache pain, or significantly decreases the amount of headache pain that you've had for so many years, for over 15 years, and this is a recovery time pain that has an end to it, it sounds like it's still, again, the better answer is to go ahead and go in and see if they can take care of this.
Yeah.
I know you're ready. I know you are ready to have
Oh, I was born
an
ready.
answer.
I was born ready.
Considering it's probably a congenital situation, I guess you were.
Yeah, whatever. But with everything that we know now, putting that all together with everything we've tried, are we better off?
Right now, before surgery?
Yeah.
That's to you because you're the one that's dealing with it, okay? We're better off in that we have a probable answer.
Right.
You know, we were able to see that slight indication that there, you know, that looked like the edge of a cyst. So that's a positive, and knowing that it's there is a positive. Dealing with pain, extreme pain, and not knowing the cause is a horrible situation. It makes it kind of even hurt more, I think, and that's not your imagination because it causes anxiety, and anxiety,
Right.
you know, and this stress, and stress makes pain worse. So, can we do anything about it? Nothing, not really, on our own, other than what we've been doing, which is using the pain meds that have been prescribed to you, which do not include opioids. No opioids allowed in that body. But you do have other things that help headache pain, and we'll have to continue to rely on those. I would say continue to hydrate because part of this pain may be from the lack of flow of CSF. So if we can get flow from other directions, I think it's important to keep the CSF, you know, topped off. So you need to stay hydrated.
Yeah.
Other than that, you know, there's just really not. It hasn't changed where we are at, other than giving you a light at the end of the tunnel, and that helps. Now that said, there's also, you know, like what they call in a job or an employment, they call it short timers disease, where things seems when you're waiting for resolution of something, like waiting to leave a job. You're in your last few weeks of work, everything seems so much worse. And I think definitely when you're dealing with pain and you see hopefully a answer and a decrease to that pain, it may seem a lot worse. It's definitely harder to put up with. You want it now. You want it to be resolved now.
Yeah.
We'll talk to Martha and schedule your surgery, and we'll let her know that we want you to be on a waiting list in case there is a sooner available surgery.
Yeah.
If they do such a thing with surgeries. If they do the waiting lists for surgeries. Does that answer your question?
Yeah.
Okay.
So, another question that I have regarding surgery is with the tumor resection.
Cyst, not tumor.
With the cyst resection.
Uh-huh.
Will there be cognitive improvement?
That's pretty much impossible for them to actually say right now.
Yeah.
But here's what we saw. We saw that your fourth ventricle is so enlarged that it has pushed your cerebellum way back. I mean, by half the size of the cerebellum, at least in one of the images that we saw. Keeping in mind that when you're looking at an MRI, you can't actually get kind of a three-dimensional look. You have to kind of put that together in your brain.
Right.
I have to put it together in my brain to try and, you know, visualize all these slices of the image. But at the biggest place where he landed it, looking at the biggest size of the fourth ventricle, it was extremely enlarged, and it looked like it had pushed back, you know, most of your cerebellum way back there. What happens? is again a question for the pre-op appointment. What happens with the cerebellum when that pressure is no longer there? Yeah, we'll have to get more information on that. But I will tell you this: if we know that a lot of your issues are due to pain.
Yeah.
And if we can reduce the pain, we can improve your processing speed, we can improve your memory, we can improve, because your focus can improve if the pain is not there. If you can focus better, your memory will improve. There's a possibility that your gait might improve. We just don't know. And I can see that they can't really make predictions, because that would be so changeable from person to person, right?
Yeah.
As he said, he might see another patient. Sorry, I need to see if we can get over. Okay. He might see another patient who has that much of an enlarged ventricle and has no symptoms whatsoever.
Yeah.
Although I tend to think, and to I guess not think, but wonder, sometimes when they say a person has no symptoms whatsoever, if that is completely true, or if those symptoms have been misdiagnosed and attributed to something else. Which
is always possible.
And that's could very well be the case for you.
Yeah.
We just have to wait and see, and I know that's so hard.
So we're heading to lunch?
No, you have your lunch in your backpack. We're heading to work.
Yeah.
And then you can eat at work. And I will make my drive back across town.
Yeah.